What we're doing today is we're going to start with upper extremity critique, and this comes from Martensen's Radiographic Image Analysis, 5th edition. And I'm going to start with fingers, probably go up through forearm in this particular video. I'm not going to get into general positioning quite as much. I have to talk about it to some degree, but I'm not going to get into detail. I will link the upper extremity playlist in the comment section or in the description of this video so that you can go back and view those. So what we're going to talk about are first off are the image receptor and marker placement, orientation of the image receptor, and collimation. So the required information that's going to be on every image should be scanned in if you're using a CR and DR system. So those things will be the facility, some sort of patient identifier, be it a number or the patient's name. Some hospitals, some facilities use both a patient identifying number and also the patient's name. The date of the exam has to be on the image as well. So the reason that some of your institutions will use both is because it's more specific. Date of birth is another marker that they may have on the image. And the reason for so much redundancy is because if you have two people with common names in the hospital at the same time, it's harder to mix them up if you have multiple identifiers. So if the patient has two patients have the same day, same names, their date of birth is probably not going to be the same. So you should be able to differentiate them that way. But also if they have a unique identifier and a number, then it makes it a little bit more difficult that way as well. So we'll talk about marker placement, image receptor positioning. We'll talk about radiation protection, which primarily is going to be your collimation. There's some differences between CR and DR and how you can utilize the equipment a little bit better. So with your fingers, you're usually going to be PA and lateral. Sometimes you may include an oblique. So artifacts we're going to talk about would be splints and bandages. And you should know from your positioning that if the patient's in a splint, for fingers, it's really not all that big of a deal, but once we get into larger anatomy, if the patient's in a splint, you're going to have somebody else take that splint off. If you remove a splint and it complicates the fracture, then that's going to be on you. So somebody with a higher rate of insurance needs to be taking splints off of the patients. But I will say this, that if you have a patient with some pretty severe cuts on their fingers, even on their fingers, if it's through an artery, then as the blood pumps through that artery, it can project away a little bit. So you can get it on you, and you can also make a mess on your image receptor. So be real careful in taking off bandages. If the patient's hand is bandaged, then in some cases that bandage is either keeping that projection of the arterial bleed from spraying, or possibly if you remove that bandage, you could be removing the first part of a clot, in which case it will start to spray. So your collimation, remember, this is something that I think we've unfortunately kind of gotten away from a little bit with our large image receptors. Collimation, it's important to collimate, and it's important to collimate using the guidelines that you learned in your positioning class, and that is to collimate down to about 1/2 inch from the skin level in the case of fingers. And that includes all anatomy. And the reason that we don't want to collimate all the way down to the anatomy itself is sometimes our collimators can be a little bit inaccurate. And at 40 inches, they can be inaccurate to the tune of about 3/4 inch. So if you collimate all the way down to skin level, then what you're going to have is, if your collimators are inaccurate and the light field over represents the size of the radiation field, then you're going to clip anatomy. So you don't want to collimate all the way down to skin level, but you want to get pretty close to it. So collimate, just make sure you collimate on all of your images if it is possible. So central ray location for everything that we're going to talk about is pretty much in the middle of the anatomy, and it's just a matter of picking out where that middle of the anatomy is. In our fingers, the center of the anatomy is going to be the proximal interphalangeal joint. So what we want to do is we want the central ray location in a place that's in the center of the anatomy, and the collimation opened up to include the adjacent anatomy. to just include the distal end of the adjacent anatomy. So in the fingers, that would be the distal end of the metacarpal. We'll want to make sure that whenever we put the hand down that we don't have the fingers tight together like that. If we're doing individual fingers, you just want to expose the individual finger, but you certainly want to have the fingers separated. And the purpose for that is so that you don't get soft tissue overlap between one digit and the next. And then your technique, if you have the Martensen's book on page 161, it has a table for technique, and these are suggested techniques, and it's a wide range here. So it says fingers, KVP would be 55 to 65, and then you've got a mass of 1. What I recommend, and what I think that I'm going to see in, or what you're going to see in your career, is a shift towards higher KVPs continuously. And the reason for that is because KVP, the reason we use the lower KVPs that we use now is in part because that's what we've always done. And KVP used to be the primary thing that we would use to control contrast on our films, back when we used screens of films. But the main thing that controls your contrast now is not the KVP, but it's computer algorithms. So there's really no reason not to use the higher KVP. Certainly, the higher the KVP that you use, the lower the mass that you're going to utilize, and that's going to save patient dose as well. So those are suggested. There's obviously a great difference between 55 KVP at one mass and 65 KVP at one mass. So make sure that you pay attention to your index numbers. If you are a student who's struggling with technique, that's probably the hardest thing to teach, in part because you're going to base your understanding of technique on what you consider to be a small, medium, and large patient. And your understanding of that and my understanding of that are going to be two totally different things. So I can teach you what I would shoot, a finger, a hand, a humerus with, but that's going to have very little bearing on you. So what you need to do is you need to in your mind, settle and reconcile these techniques, these KVP and mass values, for what you see in patients at any given time. So technique's tough to teach. So what we're going to be looking for then is central ray to the proximal interphalangeal joint. And what we want to make sure that we include is the distal portion of the metacarpal, distal portion of the finger, separate the fingers so we don't have any kind of soft tissue overlap. So what we want to do is we want to evaluate for a lot of different things. Are the joint spaces open? If the joint spaces are open, that means your central ray was parallel to the joint space. Okay, so this is a concept that a lot of my students struggle with. That is the relationship of the central ray to the joint space. So joint space, in order to visualize the joint space open, it's like this. You can see through where my hand is here. And that is because your line of sight and my line of sight are matched up and they're parallel to this area right here going through that space. So that's parallel to the joint space. Your central ray is going to be perpendicular to the anatomy. So the joint here, your central ray is going to be perpendicular to the joint like that. But to go through the joint space, it's got to be parallel. So it's both perpendicular and parallel. It's perpendicular to the anatomy, parallel to the joint space to make sure that it's open like that. So where we have joint spaces that are not going to be open is when we have bent fingers, like what we're seeing right here. Very common in patients who have things like rheumatoid arthritis and things like that. Their fingers will be sometimes a little bit deformed because the articular ends kind of eat away, and they might not be able to straighten their fingers out. Also, because of trauma, they might not be able to straighten their fingers out as well. So, but that's what a closed joint space is going to look like as opposed to an open joint space, and that is because our joint space is at an angle to our central ray. It's not perpendicular to the image receptor, and it's not parallel to the central ray. So make sure that you've got the fingers straightened out as best the patient can, and then your central ray is going to be perpendicular to that knuckle, but it's got to be parallel to the joint space. Very important. So this is kind of an illustration of what I was just talking about. If the finger is bent, if the joint space is at an angle, then what we get is the proximal, in this case, the proximal phalanx projected down onto the distal portion of proximal phalanx projected down onto the proximal portion of the middle phalanx, and it closes the joint space up. So in order to open that up, what we need is the central ray to be going straight through the joint space, parallel to the joint space like that. If your patient can't straighten their fingers out, it may be helpful to shoot AP instead of PA. Sometimes with AP, it's also going to create some problems. Like in this case, it's not a perfect AP. Most of the time we shoot our digits PA, but in this case it's going to be AP. But what we see here is we're going to have the same problem. We've got an elevated proximal phalanx, so we're going to have a closed metacarpophalangeal joint. But in this case, if this patient is, if this is an accessory view, so to speak, just so that we can see those open joint spaces because the patient can't straighten their fingers out, that may be the reason right there that we've got that angulation. I have shot some hands AP simply because the patient couldn't straighten their fingers out. The most notable was a patient that he broke and severed the tips of each one of his fingers, reaching into the I don't even know what you call it. It's the port where the grass clippings come out of the lawnmower. He left the lawnmower running and reached in there to clear it out. The grass was wet and he reached too deep, and he took the tip off of each one of those fingers and disarticulated each one of the phalanges. So he had no control of his fingers. He came in, we unwrapped the hand, and his fingers were just dangling, so I had to shoot him AP. So AP is a potential. Oh, and to kind of finish that up, the guy had diabetic neuropathy, so he really didn't feel it. It was tragic for him to lose all that, but he didn't feel it all that much. So again, if you have a situation where the patient's full of hardware, like what you're seeing here, then that might be an option to shoot AP. Just know that in some cases like this, you're just not going to be able to get each one of those joint spaces perpendicular to the image receptor or parallel to the central ray. So I assume that these were taken in surgery. And in surgery, if you've ever done any kind of surgery rotation, you know that the rules for positioning and textbook positioning are really not a thing in surgery. So your technique, very subjective. We're using lower KVP just because we don't need the increased penetration. High contrast is going to be provided by the computer algorithm, but between individual digits, there's no change in technique between them. I know sometimes some students will get into the mindset, because we start with a chest x-ray, that the laterals always need more technique than the PA, and that's just not true. In, for example, ankle, you're thicker anterior to posterior than what you are laterally, so your technique may actually need to decrease for a lateral ankle as opposed to an AP of the ankle. So don't get yourself locked into that mindset. You're not going to need any kind of technique adjustment between them. So you are going to use lower KVP. Again, the Martenen book has up to 65 KVP. And what we're going to talk about is metacarpals, phalanges, and we're also going to talk about metatarsals and the phalanges and the toes all at the same time, because the positioning variations sometimes are similar between those. So what we want to be able to visualize is both the cortical and trabecular bone, and we also want to be able to visualize the soft tissue around it. Some of your technologists will tell you to look for the fingernail or the toenail to determine whether or not you've got rotation. That's just not a very good indicator of rotation, because sometimes your toenail is not going to be centered over the middle of, especially toenail, over the middle of the anatomy, especially on the pinky toe. Some patients, their toenail is kind of on the side. So it's just not a very good thing to use. So your technique, low MA with short exposure time, focal spot size. The reason I mentioned low MA is because sometimes your focal spot size will be dependent on your MA. So if you set a 400 MA, you're not going to be able to use a small focal spot. So you want a low MA, so no higher than 200 MA, so that you can get your focal spot, your small focal spot. So focal spot selection is important. exposure time variables, just to get your mass. And you want to utilize as short an exposure time as possible, considering the MA station that you're going to use. So you want to use the highest MA station possible and still be able to get your small focal spot. So small focal spot, detail cassettes are really not a thing anymore. Your OID should be very, very low because you should be shooting tabletop. So if you can pull the image receptor out of the table bucky and put it on tabletop, then your OID decreases and your sharpness of recorded detail increases, and your SID is 40 inches, and you want to have no motion. Now, something to consider on this 40 inches. Some of your textbooks, including the Martenen, mentions 48 inches, and I think there was a push for a while there to get to 48 inches for everything except for what needs to be shot at 72 inches. So 40 inches is the traditional long time standing SID for most exam types that don't need to be at 72. But at that push to 48 inches, I don't think really gained any momentum. So we're still shooting at 40 inches. If you happen to shoot at 48 inches, that's fine. If you decide to try to shoot at 40 inches, just remember that you have to use your because of the inverse square law, you have to apply the direct square law and increase your mass if you increase from 40 to 48 inches. So in rotation, what we usually see is supination, which involves external rotation. So you position your patient perfectly and you put the hand down, and your patients, the longer you have them in position, the more likely they are to move. And it's subtle sometimes. So what happens in a lot of cases is that the patient has their hand flat, you go around, and then you start setting your technique. And the longer you're behind the control panel, the more the patient feels like they've been abandoned. And what happens is they start relaxing their hand. And if you saw it, what happened is I relaxed my hand as my thumb came down. And what that's going to do is it's going to push your hand into an external rotation oblique. And what's going to happen with that is that you're going to have rotation, external rotation, with the fingers partially flexed, possibly also giving you closed joint spaces with that rotation. So what you're going to do to evaluate that is look for those open joint spaces, but also look at your finger. So if you should have seen the x-ray of a hand by now. And what you see in a hand is in fingers and metacarpals and toes and metatarsals is that your especially your phalanges are kind of hourglass shaped. So they're hourglass shaped, so they're thinner in the middle than what they are on the proximal and distal end. And also what you see on a lateral is that the anterior surface is concave, meaning if this is posterior surface, it's sticking out like that, and your anterior surface is sticking inward. All right, so anterior side, posterior side. So they're concave on the anterior side, convex on the posterior side. So I'm using today a banana to illustrate this. So what you see here is I've marked this banana. The anterior side is concave, and the posterior side is convex. So if the patient is positioned so that there is no rotation, you don't really see the anterior to posterior concavity and convexity. You still see that hourglass shape on the fingers, but you don't really see the anterior to posterior concavity. What you get though is with that any kind of rotation is you'll start to see that concavity. So now we're seeing the concavity on the anterior side, and what we see also is a increase in convexity on the posterior side. So what we want is we want to see that hourglass shape on the PA, but what we don't want to see is any kind of concavity and convexity anterior to posterior. So we see the hourglass shape, and as we rotate up, what we start to see is a reduction in convexity on the posterior side. So that hourglass shape disappears on the posterior side and it exaggerates on the anterior side. So this holds true again for fingers, toes, metacarpals, and metatarsals all. So you can evaluate rotation just by looking at that. So as the patient rotates up, again, the posterior side, you lose the concavity of the hourglass shape and it becomes more almost board straight. As opposed to the anterior side, you get an increase in concavity. You get an increase in concavity. So the things we're going to look for are central ray alignment, central ray placement, central ray limitation, and that will be your collimation. We want to make sure that we don't have any soft tissue overlap. We want to make sure our interphalangeal joints are open, as well as our metacarpophalangeal joint. And if you happen to be asked to do comparison views, just be aware that some of your doctors want the comparison views on one image. So most of the time with comparison views, what we're looking at is the patient's anatomy, their anatomy, does their anatomy look like there may be something going on? Can you assess that? Can you definitively tell that there's not something going on, or do you need to look at the adjacent anatomy or possibly the same anatomy on the opposite hand? Most of the time that you see that is going to be in pediatric patients. So some of your hospitals are going to ask you to shoot both hands at the same time, both fingers at the same time, both hands at the same time, so that you can evaluate the growth plates in pediatric patients. So if you're shooting two at the same time, obviously you can't center just, if you're doing two, let's say index fingers, second digit, if you're doing two index fingers, it's obvious that you can't center on both anatomy in the proper place at one time. So because of the divergence of the central ray, you're not going to get an ideal image, but the doctor should be able to assess and evaluate what it is they want to see. What you want to do is try to get the anatomy as close together as possible. You don't want to put them so far apart that the divergence of the central ray mimics rotation. So put them as close together as possible and understand that you're going to get a little bit of distortion there. All right, so on obliques, this kind of illustrates what I was talking about before. We've got oblique, and what we've got is on the posterior side, we've got pretty much a flatness. So from the AP, let me go back to that. On the AP that's not completely torn up, you can see that you've got kind of that hourglass shape. So you got concavity on both sides, but when you get to the oblique, what you're going to have is a loss of concavity. There it is. On the posterior side, and an increase in concavity on the anterior side. So now it's pretty marked, the concavity on the anterior side, but also take notice of the soft tissue. So one of your evaluators in determining whether or not you got a good 45-degree oblique is how much soft tissue you're going to have on the anterior side versus posterior side. So what you should have is about double. All right, so considering your own anatomy, you can mash on the anterior side of your finger versus posterior side of the finger, and what you'll feel is the anterior side you have much more soft tissue. So as you rotate from PA upwards to an oblique, that's what you should see. The back should be flat. The anterior should have more of a concave appearance, and then the soft tissue on the anterior side should be about double what it was or what it is on the posterior side. So what we see here is just PA. It just doesn't look oblique at all. So if it's an oblique, it's under oblique, it's under obliqued, and then over here what we've got is a lateral. And if you look on the lateral, it's kind of spoiler alert for once we get to a lateral. What you'll see is the difference between the anterior and posterior side. You have no concavity on the posterior side. You may see some convexity actually. This is awfully close to lateral. And what you're going to see is the soft tissue difference between the anterior and posterior side is going to be even greater than what it was on the oblique. So fingernail, maybe. Soft tissue, definitely. Convexity and concavity are your better ways to determine. So with your lateral, you're going to do each individual digit for the most part, and you still need separation of the fingers. So now it's going to be even more important that you separate the fingers so that you can, individually evaluate. Some of your fingers, though, in positioning is just a helpful tip that I picked up from a student one year, and she was a first semester student very early in the program, and I don't really think that she consciously meant to do this. She didn't finish the program. She was a good student, but she just decided it wasn't for her. But anyway, we were going through individual fingers, and I wanted to see what she would do with ring finger. So that's fourth digit, 1, 2, 3, 4. Remember this, even though we shoot PA projection, this is still lateral side because the anatomical position is the lateral side. So it's 1, 2, 3, 4. And I asked her to show me how to do a lateral of the fourth digit. And if you look in a positioning book, especially in Merrill's, I don't know what Bontrager shows, but in Merrill's it shows, you can't really, that's as far as I could straighten my ring finger. So to get it any straighter than that, I have to push it like that, which is going to be very painful for the patient with a broken finger. Now, the likelihood the patient has a broken ring finger, and that's the only finger that's broken, is, in my experience anyway, is pretty rare, but it could happen. So what the ring finger does, though, is it follows the pinky finger. So you can try this on yourself. If you're doing the ring finger, if you're doing fourth digit, it might be a better outcome for you to just extend the fifth digit and just allow the fourth digit to follow it. So separation of the fingers, just make sure you don't get any kind of superimposition. Which lateral depends on the digit. Remember, all the way back to your positioning textbooks, if you're leaving the thumb out of this equation, but if you're looking at the second and third digit, what you're going to do is you're going to put the lateral side down. Remember, the thumb's on the lateral side. If you're doing the fourth or fifth digit, you're going to put the medial side down. The purpose for that is to decrease OID. And first semester students, you're going to have a tendency to say, okay, well, I'm shooting, let's say, again, the ring finger. So what I need to do is decrease OID, which is the reason that you put the medial side down for the fourth digit. So I got to reduce OID, I'm going to do that. And you don't want to do that. And the reason for that is because, again, now you're going to close up those joint spaces. You don't want to do that. Even though you're going to have an increase in OID, keep the anatomy parallel to the image receptor. Otherwise, you're going to have distortion. You're going to have foreshortening and closing of those joint spaces. So, and this kind of illustrates what I was talking about before. Having the patient extend that ring finger may be very difficult for them. This is obviously an old image because that's X-ray film there. That's back when we used films and screens. So that's going to be very, very painful for the patient. But a lateral should look something like that, and we've looked at that from previous slides, so I'm not going to go through it. So the thumb, the things to consider for the thumb, number one, it's the only digit that we routinely shoot AP. The reason for that is because it's very difficult to get a PA of the thumb without magnification. So the thumb, if you lay the thumb flat down on the image receptor, the thumb is in a natural oblique position. So that's your positioning for oblique of the thumb, is the hand has to be prone. All right, so remember the difference between prone and position and projection. Prone is with the hand down. That's not PA position. Projection is in this case will be a PA oblique, but the hand is in a prone position. So in order to get the thumb, then what we would have to do to get the PA of the thumb is oblique the hand, or dip the fingers down, which would elevate the thumb. So a number of things with the thumb. Number one is the only one that we do AP, and the reason we do AP is because we can put it directly on the image receptor. It's also the only one that we include the entire metacarpal. So in my experience, a significant, I won't say the majority, but a significant number of thumb injuries have been what we refer to as a Bennett fracture or ski pole injury, and that involves the proximal portion of the first metacarpal. So we want to include the entire metacarpal. Our thumbs are opposable, so they go in and out like that, and they carry the metacarpal with it. So we want to make sure that we include the entire metacarpal. In order to include the entire metacarpal, we're going to shoot AP. How you get it into AP is up to you. If you rotate that way, that's fine. If you rotate that way, that's fine. However you get it into unrotated AP projection, it works for me. I don't really care. But you need to open up your collimation enough to include the entire metacarpal and the carpal metacarpal joint space, and actually the distal row of metacarpal or carpals. So you're going to center in this case. The other difference is that on all your other digits, you're positioning your central ray at the proximal interphalangeal joint. In this case, you're going to position at the metacarpal phalangeal joint. So the things that you need to watch for, especially if you position like this, is overlap of the hand on the thumb. So it's very common for people who position, use this as positioning for the thumb, to position and then have the hand almost vertical. And what you're going to have is all that soft tissue and possibly the bones of the hand projected on that proximal portion of the metacarpal. So just be aware of that. So a couple of things. One, oblique. We already took a look at that. The oblique of the thumb, the hand is in the prone position for the oblique of the thumb. And for the lateral, all we're going to have to do is, since we're already in an oblique, is just bend the fingers up a little bit. And that should give us a good lateral of the thumb. Keep in mind that as we oblique up, we're going to have some more soft tissue over the proximal end. So we want to abduct the thumb to make sure that we don't run into that problem. All right, so here it is. So we got the carpal bone, we've got the metacarpal joint space, we've got the entire metacarpal, we've got the metacarpal phalangeal joint all the way down to the distal portion of the thumb, and so that's good. So we've got a AP in this case and a lateral. Now I'd mentioned before that we were going to talk about a little bit of a difference on CR and DR, and two things come to mind. One is that on CR cassette, you can actually put two images on one image receptor. You probably don't see that just a whole lot, but since we have such small anatomy, you can put two on one. It would be important that if you were to try to do that, to shield one side, in other words, make your exposure on one thumb, shield the rest of the cassette, and then position move your shield to the opposite side and make your second exposure on the opposite portion of that cassette. So you could put two on one. We used to do that all the time in screen film radiography. In DR systems, you just can't do that. As soon as you make your exposure, it comes up on the image receptor. So a couple of things about that. One is that if you're putting two on one on a CR cassette, the CR readers sometimes can be kind of particular in your recognition of your collimated field. So what you might want to do is position them more towards the inside of the cassette and make sure you've got 4 good borders of collimation on both of those images. Likewise, on the DR cassettes, what you want is as close a collimation as possible. They could have collimated a little bit more on these, but you want as close a collimation as possible. The reason for that is because your DR systems are reading your entire radiation field. So let's say you're making an exposure, it's Martin's book, you're making an exposure on an image receptor, and this is your digit. If you include the entire image receptor, then it's got to read all of that information. You're going to have two problems. One is that if it reads that entire area of direct exposure radiation to the image receptor, your index number is going to come up and it's going to show that you overexposed the patient when you might have set the perfect technique and you did not overexpose the patient. And number two is that it's going to see that entire radiation field and it's going to think that your entire finger is the size of that radiation field, and it might shrink it down so that you get these little bitty images of your digits. So and those are going to be specific to your equipment type. If it doesn't minimize your image, your equipment doesn't, then that's great, but be aware that it very well might. So positioning, in this case, you see the fingers bent, that's good lateral position, and that's what we're seeing there. So the hand, again, is going to be typically PA, which is going to put the hand prone. Central ray location, in this case, is going to be to the third metacarpal phalangeal joint. You want to collimate down as closely as possible, but you want to make sure that you separate the fingers, number one, and number two is watch out for the thumb. So probably in the first semester, the most common mistake I would see on hands when I was in clinical practice and a clinical instructor is the students would be so focused on the central ray location, which should be to right here, and collimating, getting collimation really tight is what they would do is they collimate, they'd pay attention to the medial side and completely cut the thumb off. So make sure that you want the finger separated, and if that means that you have to miss position off that knuckle, well, textbook positioning is to the third metacarpal phalangeal joint, but if you have to off position a little bit or adjust that thumb, then that's fine. So make sure your fingers are separated, but make sure you don't project or collimate the thumb off. Your technique is going to be about 50% to 100% greater than your finger. So if you're using mass to adjust for that, then just 50% increase or half again as much mass as you used for the fingers, or just double it, one of the two. So most commonly in both the fingers and the hand, if we have any kind of rotation, it's usually going to be lateral rotation because the patient started relaxing those fingers. So PA of the hand, good PA, we've got good collimation all the way around. Remember that if we're looking at the hand, really what we want to see is all the way down to the distal portion of radius and ulna, all the way to the tip of the fingers, and then make sure that we don't have any, collimation of either the first or the fifth digit off. All right, so we already looked at that, so we're not going to look at it again. We're going to talk about obliques and lateral. So in both of these cases, if we're shooting PA, we're going to do lateral rotation. So we're going to start with lateral, and we're going to talk about the fan versus the extension lateral. So with a fan lateral, what we're going to do is we're going to take the fingers and separate them a little bit. So you can take the fingers and ask the patient to make an okay sign like that. And make sure that they do it loosely. What you'll see sometimes is that the patient likes to really make a good okay sign, like, mash your fingers together, and that's unnecessary. Just have them touch and then separate the fingers just a little bit, but your fingers still need to be parallel to the image receptor. So, don't dip your pinky finger down like that too much. So, okay sign, put it on the image receptor, fan the fingers out so that you can see individual fingers. And the purpose for that is because if you shoot your lateral with your fingers stacked on top of each other, if you have a fracture of one of the phalanges, you're not going to be able to make that out. Probably the most common mistake I saw with patients on lateral, regardless of, especially if it was a lateral in extension, and we'll talk about that here in a minute, is that the student would tell the patient, I want you to put your hand up there like this, like you're karate chopping it. And they would step back to the control panel and make an exposure with the thumb sticking straight up in the air like that. And you're not going to get any kind of analysis of the thumb if it's sticking up like that. So make sure that, yes, you have the patient do that, and it's good positioning, good way to describe the position to the patient. But make sure that you lower that thumb so that the thumb is also parallel to the image receptor. So this is this is an extension lateral. And the purpose for this really is for, you can see the bones, the anterior posterior separation of fractures in the metacarpals and possibly in the phalanges. But what we see in this most clearly is if the patient has some sort of foreign body. So let's say the patient works with metal and they got stabbed by something at work and they've got a foreign body inside of the hand. So if we do an extension, I want you to pay attention to what happens with the soft tissue in the palm of my hand as I bend my fingers up. As I do all this, then that soft tissue really folds up a whole lot more than if I've got the only thing I've got, out in front of my hand is my thumb. And really, if you're looking for a foreign body, and this is not textbook positioning, but if you're really looking for a foreign body, you can put the thumb up on top so that you don't have as much of that, soft tissue anteriorly. So what you're looking for a fan are fractures in the fingers. In an extension, what you're looking for is foreign body in the palm of the hand. So the technique for a lateral would be about twice as much mass as what you use for the PA. With the oblique, you got a couple of positioning possibilities as well, and just follow your hospital protocol for both the lateral and the obliques. Just know that your textbook explanation for fan versus extension is with fan, we see fractures in the individual fingers, and with the extension, what we're looking for is foreign body. So I've worked in hospitals where extension lateral was always a lateral regardless of what was going on. So in obliques, we've also got some options as well. So let's say you shoot your PA of the hand. Let's say you do the fan lateral. Then what you can do then is just lower the fingers, rotate the fingers back towards the palm of the hand, back towards the image receptor. Keep the fingers parallel to the image receptor, and you can straighten the fingers out until the index finger and the thumb, second and first digit, are parallel to the image receptor as well. So that's one option. Another option would just be to take that fan lateral and have the patient lay it down so that that OK thing there provides a prop for the fingers. So what that gives you is a 45-degree rotation, pretty close to it, just using the fingers as prop. If that's your hospital protocol, that's fine. I'm not here to tell you that it's wrong. But the other option, if you're interested in seeing those open joint spaces, is to keep the fingers parallel to the image receptor. So if you have over rotation, it starts to look more like a lateral. If you have under rotation, it starts to look more like a PA. So you evaluate your convexity and concavity. And also, though, what you see is a change in the superimposition of metacarpals on the lateral side. So you're going to evaluate those too. So here's what we've got. All right, so these are not ideal because we've got, sometimes the pictures that are provided in the publisher PowerPoint, whenever I magnify them up into a PowerPoint itself, and I save them on my computer, they just don't save all that well. And so we've just kind of got a fuzzy mess here. So if we have over rotation, what we're going to see is obviously oblique. And it's good oblique. It's a fan oblique with the fingers parallel to the image receptor. You can see the open joint spaces. But what you see then is that on the oblique, what we'll get is a little bit of a decrease in superimposition on the lateral side. Remembering the thumb is on the lateral side. I'm going to keep saying that. Thumb is on the lateral side. What we get is a little bit of a decrease in the proximal portion of the metacarpals between the second and third metacarpal. But look at what happens on the medial side of the wrist, on the pinky side of the wrist, on the proximal end. We get a pretty good increase in superimposition. I'm going to scroll back up to the PA projection so that you can see what I'm talking about. So what you see on the PA is we've got a little bit of superimposition. These are fanned out pretty well. But once we get to that external oblique, we get an increase in superimposition, maybe a slight decrease in superimposition between number 2 and 3. And then, of course, a lateral, everything should be superimposed. So with a wrist, again, we've got a number of different views. We're going to focus primarily on 3, but I am going to talk about some other ones as well. Ignore this. This is old. Again, 55 to 65 kVp would be your average kVp. And whenever we went to CR, and then especially after we went to DR, that's where our kVp actually increased. And that's part of the foundation for me saying that I think that you're going to see kVp being used as the technical factor of choice for patient size. And we're going to see an increase in kVp levels because kVp, this was kVp for screens and films. Doesn't really apply in a digital world. 60 to 65 kVp is probably where you're going to live now because kVp doesn't control your contrast anymore. It's your computer algorithm. So in the wrist, the most common wrist bone that you're going to see fractures is going to be your scaphoid. But the most common wrist fractures, okay, so there's a difference there. Most common wrist bone fracture is going to be your scaphoid. The most common wrist fractures, though, are going to be your distal forearm. So you may see some dislocations here and there of different wrist bones, but scaphoid is going to be the most commonly fractured wrist bone. But in as much as we have fractures of the wrist, clinical fractures of the wrist, are probably going to be distal forearm. For that reason, we don't want to focus just on the wrist bones themselves. So what we're going to do is we're going to center our central ray to the mid-carpal region for our wrist, but we're going to open the collimation enough to include about half of the palm of the hand and the distal third of the forearm so that we can catch those distal forearm fractures. So a couple of different fractures of distal forearm. Probably in my experience, most common in adults is what we call a Colles fracture, and that's where an older patient in a lot of cases will fall and they catch themselves, and what we have is posterior displacement of the distal fragment of the radius and possibly the radius ulna. So they catch themselves, but their forward momentum takes the distal portion of the radius ulna and it pops it backwards. The opposite of that would be a Smith fracture. Same demographic, older patients, and maybe they didn't get their arm out in front of them, but they were trying to get their arm out in front of them to break their fall. But what happened is that they hit and it pushed that distal fragment posterior. That's what we refer to as Smith fracture. In kids, the most common fractures would be your green stick fractures, your buccal fractures, torus fracture. Torus fracture is just top of green stick fracture in kids, where the cortex of the bone bows out. The definition of a green stick fracture is a fracture that's kind of like a green stick on a tree. You can't break it off easily. Whenever you break, what happens is that at the break you get a fracture on one side and the other side doesn't go all the way through. So it's an incomplete fracture. So what we want to be able to assess on our PA is what we refer to as scaphoid fat pad, or scaphoid fat stripe. So in various areas inside of your body, you've got these things that are soft tissue indicators of a fracture. Even if the patient doesn't have a fracture, the indication would be that there's a fracture present if you've got distortion of that fat pad. So what I'd recommend that you do is start studying the images when they come up. If you happen to shoot a wrist bone, start looking for dark areas that kind of parallel the anatomy, and that's what you refer to as fat pad. And so it's a soft tissue density difference between two other types of tissues. So what we get with the fat pad is it should follow the contour of the bone, but if the patient has an effusion that would indicate excessive swelling, that then would indicate a possible fracture or probable fracture, then we get distortion of that fat pad. So instead of following the contour of the bone, it may bow outward just a little bit. So that's the importance of this and being able to evaluate it and visualize it. So with our positioning, our PA, we want it unrotated. Again, our most common rotation is going to be external. We'll want our shoulder, elbow, and wrist in the same plane. And this is something that Merrill's does not point out. But if you take and you feel of your own anatomy, and I'm hoping that you can see this, if you feel of your own anatomy, you can feel your ulnar styloid process kind of poking out of the backside of your wrist, right? So what the evaluation criterion Merrill's calls for is that ulnar styloid process to be projected medially. All right, so it may actually say laterally, and in context, neither one is wrong. It's pointing that way is what we want to see. So right now it's pointing that way, which is not what we want to see. So if you put your finger on that and then you elevate your shoulder, your elbow, and your wrist to all be in the same plane, what you'll find is that it disappears. It's no longer sticking up. Maybe you can visualize the bump right there, but when I get up to here, it kind of goes away. So it externally rotates, or I guess that would be internally rotate. It rotates out and away. So you don't get that if you position your patient, if you pull the patient up to the table and you just have the patient position their wrist on the image receptor. That styloid process is going to be poking out posteriorly. You don't want that. You want it to go away. You want it to be poking out that way. So put everything in the same plane. You want the fingers bent but not clenched. All right, so you don't want to clench fist, because what happens, the purpose for bending the fingers is to lower the OID. So let's see if I can visualize this. So what you see there is an increase in OID from my wrist to this textbook. And if I straighten my fingers out, it exaggerates it. If I bend my fingers up, it'll lower it down. So you want to watch the patient as they bend their fingers up. Tell them not to clench their fist, but just loosely bend their fingers up, and that lowers the OID. Now, what you'll see maybe on the registry, if your instructor pulls a question out of a test bank or whatever, you may see reference to the carpal interspaces. So carpal interspaces are those spaces in between the carpal bones. And the carpal bones they're kind of pyramidal in shape. So they're more thin on the anterior side than what they are on the posterior side. So what that means is that if they're thicker on the posterior side, we usually shoot our wrist PA, which puts the fatter side closest to the x-ray tube and furthest from the image receptor. So what that does is it increases the penumbra, or the shadow, the unclearness. It decreases spatial resolution. So if we shot AP though, then our carpal bones would be more in line with the divergent central ray. So you may see a question at some point that says, what position would you put the wrist in to best show the carpal interspaces? And that would be that you would put it in a supine position. You may see a question say, what projection would you shoot to best demonstrate the carpal interspaces? And that would be AP. Both mean the same thing. Central ray, again, to the mid-carpal region, but you want to open up in this dimension far enough that you can see half of the palm of the hand and also the distal third of the radius and ulna. So the things that we want to evaluate for, we already talked about the fat pad. We want to make sure that we're not rotated. Medial rotation is going to be the direction we typically go. We're not likely to see rotation towards the lateral side. Again, the lateral's on the thumb. We want to make sure the ulnar styloid is in profile. We want to make sure the scaphoid has minimal foreshortening. The natural lay of the scaphoid is going to put the distal portion of the scaphoid at an angle. So if we've got our positioning, our scaphoid is in position like so. So we're going to have some foreshortening, especially the distal portion of the scaphoid. So we want to make sure that we include the distal portion of the forearm as well. So that's what it should look like. It's a pretty good PA of the wrist. So that's scaphoid. It's the lateral most bone in the proximal row of the carpal bones. So you've got all your carpal bones. You've got 4 and 4, and scaphoid is on the lateral most side over by the thumb. Most common fracture, and sometimes fractures will be on the distal end, sometimes across what we refer to as the waist, and sometimes on the proximal end. So medial oblique internal rotation, or external rotation rather. Medial rotation towards the medial side would be external rotation. It'd be a lateral medial projection. Keep everything in the same plane. And it opens a carpal on the lateral side, on the thumb side of the wrist. Specifically, what we're going to be able to visualize is a scaphoid. So from PA projection, your scaphoid looks like that. And as you rotate up, what happens is scaphoid, even though we get an oblique view of the scaphoid becomes more parallel to the image receptor. So we see it with less superimposition, less foreshortening. So again, oblique of the wrist, elevate the arm so the elbow, wrist, and shoulder are in the same plane. Mid-carpals, wrist flex to no greater than 15 degrees, meaning we don't want flexion or extension either one any more than 15 degrees. Remember, until we get all the way up to the scapula and the Gracie method possibly. All of our obliques of the upper extremity are going to be 45 degrees. In the lower extremity and the foot, we're going to use a couple of different degrees of angulation for the foot, and we'll talk about that when we get there. And we can use the fingers. There's no possible complications to use the fingers for the support in the wrist, like what we saw in the hand. You can use the OK thing for the wrist, and there's not really going to be any issues there. So if we have under rotation, then what we're going to see is the trapezium, the trapezoid superimposed, and the scaphoid should look foreshortened. If we're over rotated, the trapezoid is projected onto the capitate. So going back to our hand, what we've got is the capitate is here, scaphoid here, trapezium, trapezoid there and there. So over rotation is going to take those and put it on capitate. So that's what we should see. So we've got the scaphoid with less superimposition. Remember the oblique of the hand. Same thing applies. You can evaluate the superimposition of the medial side metacarpals, proximal metacarpals, and separation between the second and third metacarpal as well. So good oblique. If we obliqued any more, trapezium, trapezoid specifically would be projected onto the capitate. So lateral, again, we want everything in the same plane. We want true lateral position. The evaluation for a good lateral, first off, you need everything in the same plane: shoulder, elbow, and wrist all in the same plane. But if you feel of your ulnar and radial styloid processes, the evaluation criteria is going to call for superimposition of those two things. So if you feel of them, you've still got the styloid process of the ulna more posterior than the radial styloid process. So this is not something that's in the textbook, but it's something that I tell my students is you can't really use the hand to determine whether or not you've got a good lateral of the wrist. It just doesn't work real well. In some patients it will, some patients it won't, but what you may need to do is feel for those styloid processes and then put your finger and thumb directly on top of each other. What that might require is slight supination of the hand. And when I say slight, I'm talking about from a true lateral hand. It doesn't really matter where your thumb is on this one. You know, your thumb can be here, it can be sticking straight up, doesn't really matter. But in order to get a good lateral of the wrist, sometimes what you may need is maybe a 5-degree supination of the hand. And 5 degrees is very subtle. So, don't do this number, but just do a slight supination of the hand, and you should be able to visualize those two things superimposed on each other. What we're going to look for on a lateral wrist is we're going to look for the pronator fat pad, and we'll take a look at that. We'll look at the lunate and see if in your carpal bones you have a good, it kind of looks like a half moon appearance, or not even half moon, more like a quarter moon appearance, and that is what you're looking at is lunate. That's the reason we call it the lunate. So if we have slight pronation, then what we're going to have is the scaphoid is going to be projected anterior to the pisiform. What we should see is pisiform over the distal portion of the scaphoid. So if we have slight pronation, that's going to take the scaphoid, which is here, and the pisiform there, and it's going to project the scaphoid anterior to the pisiform. So as we pronate, what we're going to get is the scaphoid is going to go anterior, pisiform is going to go posterior. So that's going to cause that separation. If we over supinate, now I did tell you to slightly supinate. If you go too much, then what we're going to have is the pisiform anterior to the scaphoid. So pronator fat pad is here. That's your pisiform, this little bitty thing right there. That's your lunate, and that's your scaphoid. So you got the pisiform right over the distal portion of the lunate, or this distal portion of the scaphoid. That's exactly what you want to see. And pronator fat pad indicates, again, if it follows the contour of the anatomy, chances are no fracture. But if it bows out and away from the anatomy, that's a good indication we've got a fracture. So over here, you see that half moon appearance there, and we've got superimposition between the pisiform and the scaphoid. And it looks like on this one, we've got a slight amount of supination as well. So we have views specific for the scaphoid, and that will be our ulnar deviation. And the definition of deviation is, in some textbooks I've seen it seem to be, I won't say counterintuitive, but contrary to what we refer to as ulnar deviation. So ulnar deviation, and what most of the texts are going to refer to ulnar deviation as deviation towards ulna. So what happens is that, let me get back to an AP, or a PA rather. You see with the PA, we've got some superimposition. If we have any kind of radial deviation, then we're going to have increased superimposition between the trapezoid and trapezium and the scaphoid. But you've still got some superimposition over here as well. And what we're going to have with ulnar deviation is we're going to take the hand and we're going to flex it towards the patient's ulna. So this is ulna over here. We're going to flex towards the patient's ulna. And what that's going to do is it's going to take the bones on the lateral side of the wrist and it's going to scrunch them up. No, I just said that exactly backwards. It's going to take the bones on the medial side of the wrist and it's going to bunch them up. It's going to take the bones on the lateral side of the wrist. And I say this so many times more for my benefit than yours, and that the thumb is on the lateral side. So it's going to take the bones on the lateral side of the wrist and it's going to spread them out. So it's going to desuperimpose the scaphoid a little bit. So there we go. Ulnar deviation or ulnar flexion, sometimes you'll hear it referred to, is just the movement of the wrist in that direction. We've got the Stetcher method that you see in Merrill's calls for a 15-degree cephalic angulation. So what that does is because and that's with the hand straight and the palm just on the image receptor, and it takes the scaphoid and it puts the central ray more perpendicular to the distal portion of the scaphoid. So what that does then is if the patient has a fracture, kind of like if my interphalangeal joint here represented the fracture, it would put the central ray more parallel to that joint space of the fracture. It increases the chances we can see that fracture. So every hospital I've ever worked in combined the two. So in the positioning textbooks, these are two different things. The ulnar flexion or ulnar deviation is one, and then the Stetcher method with that 15-degree cephalic angulation is another one. It's totally different view or different method, different projection. The projections are the same, but different exam. In every hospital I've ever worked in, if they did an ulnar view or navicular view rather, a navicular view, they combine the two. So they did the ulnar deviation, ulnar flexion plus the 15-degree cephalic angulation. What you see in most of your textbooks, though, is your collimation is open to include the entire wrist, and you just don't need to see that. What you need to see is the scaphoid, which is about the size of the tip of your pinky finger. So you don't need all the entire wrist. You can collimate down to just the scaphoid. Don't over collimate. Don't try to collimate all the way down to something the size of your distal portion of your fifth digit. Because, again, your collimators can be inaccurate, but certainly you don't need to include the entire wrist. So those are your possible locations of fractures. You've got distal fracture, you've got a waist fracture, you've got a proximal fracture, then you got that scaphoid fat pad. So we're in obvious ulnar deviation, and what we see then, again, are the carpal bones on the medial side of the wrist are kind of bunched up, and we have that separation on the lateral side of the wrist, specifically desuperimposing the scaphoid. So that's the ulnar deviation. If we have the included cephalic angulation, great, then we're more likely to see the fractures, especially in the waist and the distal portion of the scaphoid. So we're going to do forearm, and then we're going to call it good. So back to the wrist technique. I didn't touch on that. Your technique for the PA of the forearm versus lateral, you're going to use about double the mass for the lateral of the wrist. On forearm, the technique's going to be the same. So if you're using a 14x17 image receptor size in a CR setting, then what you can do is you can still do a 2-on-1 situation. So this is again CR setting rather, and if you're using DR, this doesn't really apply. But if you're using CR, you can still put two images on one image receptor. So what I recommend that you do then is to put the first one, do the lateral first, put everything in the same plane, position for the lateral, have the patient point the thumb straight up at the sky, and put the lateral on the side of the image receptor that would be closest to them so that they don't have to reach all the way across it. And the reason I say that is because if you put the AP, let's say you're doing the right arm, right forearm, and you put the AP on the side that would be closest to the image receptor, the patient may not be able to reach across the image receptor far enough in order to keep you from having superimposition between the double exposing the image receptor. So your only option there then would be to shoot another one on a separate image. What you don't want to do is put the AP on one and then say, well, I've got the AP, but the patient can't reach far enough to get the lateral, so I'm going to turn the image receptor all the way around and do the lateral on the opposite end. I've seen radiologists just pitch a fit for having one projection going one way and the other projection going the opposite direction. So just keep that in mind. That's what the question mark there is. First off, you can't do it on DR. And if you do it on CR, just make sure that you've got the arms going in the same direction. So keep in mind that you've got a divergent central race. So sometimes, if the patient's complaining of pain in the wrist, the forearm, and the elbow, and the ER doctor or whoever it is, the ordering physician, whoever it is, who ordered that exam, you have to, because of the divergence of the central ray, you have to take each individual exam separately. So you have to do a wrist, you have to do a forearm, you have to do an elbow. What you might do is go to that ER doctor and say, hey, do we need all three of those, or can I, just shoot a forearm? Would you be satisfied with just forearm? But if they truly have pain in all three of those places, you really kind of need to be able to assess each one of those. So the fat pads, especially in the elbow that we're going to talk about in the next video, if you don't get centering directly above the elbow, you can hide those fat pads. And one of those fat pads is crucial to see. So because of the divergence of the central ray, you have to do each one individually. You can't do fingers all the way up to elbow in one image. With an obvious exception, if you're doing something like a metastatic survey or possibly evaluation for child abuse or something like that, then you can. But if you're looking for detail, then you need to do those individually. You can utilize the anode heel effect. I know Popeye, excuse me. When I first started teaching, everybody knew who Popeye was. Popeye was a sailor man that had great big forearms. He was a little scrawny upper arms. His forearms were huge, but the rest of his arm was little. So what we have then are patients sometimes who have these great big forearms that provide imaging issues. So what we might have to do is because some of these patients have great big forearms and the wrist comparatively is so much smaller, then we might need to utilize the anode heel effect in order to even out those exposures between the two. So in those cases, what we would do is put the anode, which gives lower radiation exposure. We might put the anode over the wrist end and then the cathode over the elbow end of the patient. So that's Popeye right there. You can see why I mentioned him. Massive forearms. He's got no meat on his upper arm at all. So Um, the reason we do AP of the forearm is it prevents the radius from crossing over the ulna. So when we have rotation, the elbow, when we rotate our forearm, or rotate our wrist from supination to pronation, the elbow may move a little bit, but most of the rotation is at the ulnar head, which just swivels and it crosses. It takes the two bones that are, I won't say completely parallel to each other, but they're kind of parallel to each other. So it takes the wrist, the bone on the lateral side, which is the radius, and it crosses it over the ulna. So we might get a little bit of a turn up here, from the shoulder, but most of our rotation happens right there, and it takes those two bones and it crosses them over. So we do AP to prevent that, if at all possible. So if the patient doesn't have a fracture and they can, then you want to extend the arm, put everything in the same plane, extend the patient's arm, and supinate the hand. So with our fractures, if you have a patient who has a suspected fracture or an obvious fracture, what you want to do is you want to support proximal and distal to the fracture. So you want to pick it up, not just in the middle, or have the patient just pick it up all by themselves. But if it's obviously an unstable fracture, you want to pick the patient's arm up as a unit, supporting proximal and distal. So if there is a fracture, then what you want to do is try to put the joint that's closest to the fracture in the proper position. Now, what I mean by that is that if the patient has a fracture and they can't supinate, then let's say if our fracture is on the proximal end, we'll want to at least get the arm extended as much as possible. And if they can't supinate, that's going to be okay. And try to get the joint that's closest to the fracture in the most proper position that you can put it. Sometimes what you may have is an AP of the proximal end, roughly, and a PA of the distal end. So central radius is going to just be the middle of the anatomy. Radius and ulna should be parallel to each other. The wrist should be in an AP top orientation, AP projection. Proximal humerus AP, and the elbow should be extended as much as possible. So what this is going to entail is you get the patient seated at the table, have them extend their arm, and get their shoulder very, very low. So what we want is a humeral condyles parallel to the image receptor. That's just straight out of Merrill's. So our rotation, we're going to detect our rotation by assessing the radial tuberosity and how much superimposition it has over the proximal end of the ulna. So what we want to see is half an inch to a quarter inch superimposition. So if we have greater than that, then it's going to be internally rotated. Less than that, it's going to be externally rotated. All right, so what we have then is we have let me show you. So we've got, this is a radial tuberosity right here. All right, so the radius, just keep it how we're seeing it here. We've got our left arm, right? So if we have internal rotation, what it's going to, I'm trying to point at this. What it's going to do is it's going to take that and it's going to increase that superimposition. So when we get to the elbow, what you're going to see, we're going to do a 4-view elbow, which is pretty uncommon in my experience. Some of our clinical sites do 3, some of our clinical sites do 4. But if you have an external rotation, first off, it's going to be difficult for the patient to get into external rotation. But if they do get into external rotation, what we're going to see is a less superimposition of this thing right here. That's your radial tuberosity onto the ulna. So that shadow right there is actually the radius. So as we externally rotate, what that's going to do is going to pull that off of the radius so that we can see it separate. So in our elbow, external rotation, that's actually what we're looking for, is desuperimposition of radial head, desuperimposition of radial tuberosity. So that will be AP elbow external oblique, and we'll get there in the next video. So internal rotation, that increases. What we get is more superimposition all the way down. If the hand itself is pronated, then what we're going to have is complete crossing of the radius over the ulna. So lateral forearm, We've got, lateral projection. We're going to have everything in the same plane again, thumb pointing straight up at the sky. We're going to visualize fat pads on both ends, proximal and distal end. They should be present, but it's not going to be optimum again because of the divergent central ray. We should be able to visualize that pronator fat pad on the wrist. We should be able to see the anterior fat pad on the distal portion of the humerus. Distal portion of the humerus has two, anterior and posterior, and then also we've got a supinator fat pad in front of the radial head. So our humeral condyles are not going to be perfectly superimposed. When we get to the elbow, we're going to talk about that. You should look like your a perfectly round artifact, so to speak, is present on your lateral elbow if it's positioned properly. But on your lateral forearm, you're not going to see that. So what you're seeing in that round artifact are the two condyles, the distal portion of the humerus, perfectly superimposed. But because of the divergence of the central ray, what that's going to do is it's going to project one more posterior than the other. What I mean by that is we've got this thing here. So with the divergent central ray, it's pointing back that way, right? So what that's going to do is take the humeral condyle, all right? So this is your humerus. So the humeral condyle, this is the posterior portion of the humerus, anterior portion of the humerus. The divergent central ray is going to take the one that's furthest from the image receptor and it's going to project it posteriorly. So you're going to have separation of those two. You're not going to have perfect superimposition. So again, if you need to see the distal portion of the forearm, and realistically, you're probably not going to visualize that posterior fat pad on the distal portion of the humerus if you're shooting a lateral of forearm, just because it's going to project the humerus back, posteriorly onto that posterior fat pad. All right, so lateral forearm, distal, same as detecting wrist rotation. You're still going to have some distortion because of divergence of central ray. On the proximal end, okay, so I said we were going to finish this with discussion of the forearm, but really it's kind of getting into the elbow. So what we get is on the proximal end, our evaluation again goes back to people with great big forearms. So what happens in a lot of cases in both the lateral of the forearm and the lateral elbow is if the patient has a great big forearm, then what might happen is that their forearm may be elevated off of the image receptor, kind of like that. And if that's the case, then what it's going to do is it's going to take and it's going to separate those condyles that are on the distal portion of the humerus. So condyles should be stacked right like this. So if we've got one that's anterior, much anterior than the other, then that could indicate that what we've got is let's say, and I'll show you when we get to elbow how to tell the difference between the two. But if the one that's elevated is further anterior than what it should be, that indicates that either the elbow was elevated or the patient has those great big forearms. So if the one that's on lateral is posterior, what that indicates is the patient's positioning error is that the hand is elevated. So we've got those two things, and we've also got this type of rotation as well. So if you don't get the patient down to where the shoulder, the elbow, and the wrist are all in the same plane, then you might have this dipping kind of thing going on too. So remember, what we're talking about are the condyles of the humerus. So with the humerus, that's distal and this is proximal. So if we've got separation between the two and the side that's furthest from the image receptor is distal to the side that's closest to the image receptor, what that indicates is that the shoulder was elevated, the elbow was depressed. So basically what you did was you positioned like so. Instead of getting everything in the same plane, you just had the patient sitting upright, and you've got that going on. So if you've got the other possibility where the side that's closest or furthest from the image receptor is projected proximal, then the patient's just too low and their shoulder's depressed and their elbow is elevated. So we're going to dial that in just a little bit tighter whenever we get to the forearm here in a minute. We're naturally going to have some distortion of the condyles for the lateral of the forearm, again because of the divergent central ray. So the two condyles that I'm talking about are what we refer to as trochlea and the capitulum. So if you still struggle with which one is which, I usually use this to kind of straighten them out. Word association. Word association is a big thing. So if you pop the hood on your car, let's say your car overheats because you've lost some coolant in your car and it's starting to steam out from underneath the hood. If you pop your hood, what should be way up front, unless you're working off a air-cooled engine like an old Volkswagen Beetle or something like that, what you should see right up front, very first thing, is what we refer to as the radiator. All right, so you got radiator, radius, kind of go together. So your radiator is right up front. The radiator is where the coolant goes through to cool down before it goes back into your engine. I'm not going to get into auto mechanics, but that's what it does. Its purpose is to cool down the fluid that's running through your engine. And you can take this little round thing off the top, that's the radiator cap, capitulum, take the radiator cap off, not while it's steaming like that, but whenever it's cool, you can take the cap off and you can put more fluid in it. If you take that cap off while it's still hot, it'll spew, it'll burn you badly, so don't do that. Wait till it's cool, but that cap is on the radiator, so the radius articulates with the capitulum. Radiator cap, radius, capitulum. So how we're going to differentiate between which condyle is which is we're going to look at the condyle and then we're going to look at the anatomy that appears to be articulating with it. So the thing that is closest to the capitulum should be your radial head. So you should be able to differentiate between the two. The trochlea articulates with the ulna. If you can just remember radiator cap, you can remember radius capitulum, and then the other two go together. So this is not your perfect diagram of a lateral of the forearm because we're not bent to 45 degrees, or 90 degrees rather. But what you see are all those things that we talked about before. So you see separation of your capitulum and your trochlea. So we've got rotation. In this case, it looks like what we have then is, since this is the radial head, this would be the capitulum. And so what we've got then is a situation where the radial head and the capitulum is distal. So again, they position the patient like that. No, it's proximal. So we've got the patient position with the shoulder depressed. So what we've got then are 4 fat pads that we have to concern ourselves with. We already talked about this one. This is supinator fat pad, and it's pretty obvious. Should be pretty obvious that where you get your supination is at the radial head. You get that rotation. So that's supinator fat pad. So you've got 2 fat pads on the distal portion of your humerus. This is the anterior fat pad, and if it's displaced, it sticks way out like that, and the lower portion, the upper portion of it remains relatively intact, but the lower portion pushes way outward, and that's what we refer to as the sale sign, and that's an indicator that you might have a fracture of the distal portion of the humerus, which may be very difficult to visualize. The posterior fat pad sits inside the olecranon fossa on the backside of the humerus, and you don't see it unless there's almost a certainty that you've got some sort of fracture there. So you want to be able to visualize all of those, and again, you probably are not going to see the posterior fat pad unless it's really badly displaced because of the divergence of the central ray. But when we get to elbow, it's vitally important that you get a good lateral elbow so that you can assess that. So, if this is pushed outward, it's a good indication you got a distal radius ulnar fracture. If this one is displaced, it's a pretty good indication that you got a radial head fracture, a radial neck fracture. Anterior fat pad indicates you might have a distal portion of the humerus fractured. And if you visualize the posterior fat pad at all, I'll almost guarantee you've got a fracture there. So you want to be able to see all of those. So pretty good, excuse me, pretty good lateral forearm. Again, you just don't see the characteristic appearance of the proximal end, those two condyles stacked on top of each other really well. Because of the divergence of the central ray, it's just not a good image of either the wrist or the elbow. But that's not what we're looking for in this case. We're looking for the forearm itself. So I'm going to pull up there, and we'll pick up with the next one at elbow. We've already talked about the elbow and the mispositioning of the elbow, and that's the separation of those condyles and the position of the forearm and the shoulder in relationship to those. So when we get to the elbow in the next video, I'm not going to spend just a whole lot of time on them. I'm going to assume that you've already kind of got that figured out. But we are going to look at some images to kind of see what it is that we're looking at there. So I hope this was helpful. As I go through the rest of this chapter, I'll try to link each one of these videos so that you can have them kind of in an individual playlist. If it was helpful to you, please like, subscribe, share.